Channel. In this video I will discuss hemolytic uremic syndrome. Hemolytic uremic syndrome. So it can be defined as a thrombotic microangiopathy that is characterized by a triad of microangiopathic hemolytic anemia, thrombocytopenia and acute kidney injury. So it has a triad of microangiopathic hemolytic anemia, thrombocytopenia and acute kidney injury. So what are the causes that can cause hemolytic uremic syndrome? It is mostly, the most common cause is post-Shiga toxin producing E. coli, that is E. coli O157H7, leading to bloody diarrhea. And when this toxin enters blood, then it causes endothelial damage. It causes endothelial damage, and therefore there is activation of the thrombi formation in the blood. Then the atypical causes include complement dysregulation, either it is genetic or acquired. Other causes include drugs like cyclosporin, then pregnancy, infections and certain autoimmune disorders like SLE. So these are can lead to hemolytic uremic syndrome, but most common cause is E. coli O157H7. What are the clinical features that are seen mostly in hemolytic uremic syndrome? If there is E. coli O157H7, then there is history of dysentery, that is bloody diarrhea, dysentery in typical HUS. It has a triad of hemolytic anemia, microangiopathic hemolytic anemia, and the patient has pallor, jaundice due to rise in indirect bilirubin. It is due to rise in indirect bilirubin because it is intravascular hemolysis and fatigue. Then patient has thrombocytopenia because platelets are consumed in clots, consumed in small microthrombi formation. So it leads to petechia, purpura, mucocutaneous bleeding, that is gum bleed, etc. Then there is acute kidney injury, oliguria or anuria. The patient may have edema and hypertension. This acute kidney injury may be due to increased hemoglobin release from the RBCs that are damaged and lead to acute tubular necrosis. So it is a triad of microangiopathic hemolytic anemia, thrombocytopenia and acute kidney injury. And you should remember that acute kidney injury in case of hemolytic uremic syndrome is more severe than thrombotic thrombocytopenic purpura. How will you investigate this? First you will do CBC. CBC will show anemia and thrombocytopenia. Then you will do peripheral smear. You will see on peripheral smear these schistocytes. Schistocytes are fragmented RBCs. When RBCs pass through these microthrombi, then due to shearing forces RBCs are damaged, then fragmented, or helmet cells. These are schistocytes that are seen on peripheral smear. Also when there is hemolysis, then there is increase in the LDH, indirect bilirubin, and heptoglobin is decreased, because when there is hemolysis, then hemoglobin is released and this hemoglobin binds to heptoglobin. So heptoglobin binds this hemoglobin and therefore free heptoglobin is decreased. Then you will do RFTs, renal function tests. You will see there is increased urea, creatinine, there may be hematuria and proteinuria, and this is mostly hematuria is due to hemoglobin loss in the urine. Coagulation tests. Coagulation tests are done to rule out the DIC, and PT, APTT, INR in this case are normal. PT, APTT, INR in this case are normal. So in this way you can rule out DIC, because in DIC you also have thrombocytopenia and hemolytic anemia. On stool culture you will identify E. coli O157H7. E. coli O157H7, that is the Most common cause of hemolytic uremic syndrome, E. coli O157H7. For this purpose, you will do stool culture. And then complement studies in case of atypical hemolytic uremic syndrome, in which there is dysregulation of the complement system and therefore complement activation leads to hemolytic uremic syndrome. So complement studies are also important. Now you have diagnosis of HUS. How will you manage the hemolytic uremic syndrome? It is actually mainly supportive treatment that is required for hemolytic uremic syndrome. For hemolytic uremic syndrome, you have to hydrate the patient, especially when patient has dysentery due to E. coli O157H7. So you have to give fluids. You have to manage the hypertension. If there is acute kidney injury, then it can lead to hypertension, so you have to control hypertension. And when there is severe acute kidney injury and there is indication for dialysis, then you should go for dialysis. You should avoid antibiotics, either it is E. coli O157H7, because these antibiotics actually worsen the hemolytic uremic syndrome, and also antimotility drugs should be avoided because you are giving a medium for bacteria to grow. So antimotility drugs are also stopped. Plasma exchange can be done in atypical cases, especially in which there is no diarrhea, and atypical hemolytic uremic syndrome and no diarrhea. In such cases, you should go for plasma exchange, especially if it is complement mediated. So initially you should go for plasma exchange in atypical hemolytic uremic syndrome. Especially for this complement mediated hemolytic uremic syndrome, you should give Eculizumab. Eculizumab is actually C5 inhibitor, that is the component of complement, and when you give this anti-C5 monoclonal antibody for atypical HUS, you are actually treating complement mediated HUS, and in this way you can treat complement mediated HUS. So this is all about hemolytic uremic syndrome.